Welcome to the Cancer Research Institute Cancer Immunotherapy and You Patient Webinar Series. Today's date is July 28th, 2017, and the topic for today's webinar is How Immunotherapy Can Help Children with Cancer. This webinar is being recorded and will be made available on the Cancer Research Institute website and our YouTube channel. My name is Brian Brewer, and I'm Director of Marketing and Communications at the Cancer Research Institute. CRI is a nonprofit organization that is dedicated to saving more lives by funding research that aims to harness the immune system's power to conquer all cancers. This work has contributed to the development of life-saving immunotherapies for a variety of cancers. We present this webinar series to patients and caregivers to help you understand what immunotherapy is and how it differs from other treatments, to provide information on the latest developments in research and treatment, and to connect patients and caregivers to immunotherapy clinical trials. Before we begin, I'd like to thank our generous sponsors who have made this webinar series possible: Bristol Myers Squibb, Genentech, Regeneron, and Advaxis Immunotherapies. I'd also like to mention that if you're interested in learning about cancer immunotherapy from the experts, if you'd like to connect with other cancer patients and caregivers, or if you'd like to explore your clinical trial options, the Cancer Research Institute is hosting an Immunotherapy Patient Summit series in 5 cities across the United States, with Saturday summits coming up in Chicago, New York City, Houston, and Tampa. The summits are free to attend, and we encourage you to register today at cancerresearch.org/summit. There is also a live streaming option for those who cannot attend the summits in person. Now it's my pleasure to introduce today's expert speaker. Dr. Marie Bleakley is an associate professor in pediatrics at the University of Washington School of Medicine, an associate member of the program in immunology at the Fred Hutchinson Cancer Research Center, and an attending physician with Seattle Cancer Care Alliance at Seattle's Children's Hospital. Dr. Bleakley's work focuses on developing new immunotherapy transplant strategies that optimize the activities of transplanted T cells by separating the graft versus leukemia effect from graft versus host disease in order to reduce transplant complications and improve outcomes in high-risk acute leukemia patients. In addition to sponsoring several successful investigational new drug applications to the FDA, she has served as the principal investigator on several clinical trials, some which deplete certain donor T cells to prevent graft versus host disease, and one involving genetic modification of donor T cells using a lentiviral vector to express a specific T cell receptor. Dr. Bleakley, thank you so much for joining us today.
Good morning. Thank you, Brian. It's a great pleasure to be here and to speak with you about pediatric immunotherapy. As you're aware, cancer in children has greatly improved survival over the past 50 years. In the 1960s, childhood cancer was fatal in most patients, whereas these days, the majority of patients survive their cancer. Immunotherapy is part of that story and an increasingly important part of that story. It's important because it's going to be allowing us to back on some of the more toxic therapies that we've relied on over time. Cancer is still the second leading cause of death in patients up to the age of 14. And just as importantly, the treatments that we need to use these days still can cause long-term debilitating side effects. And immunotherapy is going to be an important part of the solution to that long-term toxicity. The most common childhood cancers are cancers of the blood and of the brain and nervous system. And quite excitingly, new immunotherapies are addressing these issues. There's been some very exciting clinical trials in the area of leukemia in the recent years. And at the end of last year, some breakthrough studies in immunotherapy for brain cancer. So I'm going to introduce now a number of the immunotherapies that have been approved and are on the verge of approval. So The first real demonstration of the power of immunotherapy was blood and marrow transplantation, also known as bone marrow transplantation or stem cell transplantation. And the idea of this is that a child, typically with a hematological malignancy such as a leukemia, who has either high-risk disease or has developed a relapse of their disease, is subject to a process whereby they have received intensive chemotherapy and often radiation, and then in order to help them recover from the toxicity of those therapies, they're given cells from a healthy donor. Those cells allow them their bone marrow and blood system to recover from that intensive therapy, but they do more than that. They provide additional cells, including immune cells, lymphocytes, that are able to recognize the cancer in the patient and react against it. So to search and destroy against hiding cancer cells. So the effective blood and marrow transplantation is twofold. One, it's the intensive therapy that we give before we give the cells, and then it's the cells themselves, the immune cells that can provide an immune effect. Blood and marrow transplantation was developed in the 1960s and has become increasingly effective over several decades. The limitations are it's not curative for all patients, and we have to continue to increase its effectiveness. And also there are considerable problems associated with that intensive therapy that we need to use before infusing the cells. And that can cause long-term effects in the recipient. So what we'd like to do is to be able to back on that intensive therapy and make the cells that are being infused smarter and better at seeking and destroying the cancer cells by themselves. So we're aiming to develop smarter transplantations to overcome the current limitations. T-cell immunotherapy is a form of immunotherapy where we take particular immune cells, lymphocytes, and we either select or introduce particular molecules that helps those immune cells recognize the cancer cells. So there's the great excitement in the immunotherapy field in the last 6 or 7 years has been the development of chimeric antigen receptor T cells, particularly for B lineage or B cell acute lymphoblastic leukemia, the type of leukemia that expresses a molecule called CD19. So the CAR T cells are cells that are immune cells that are engineered with a synthetic receptor that is specific for the CD19 molecule that you find on B cell leukemia and also on healthy B cells in the body. And those CAR T cells can be given as an infusion, and even in patients with very resistant B cell acute lymphoblastic leukemia, the clinical trials have been showing some very exciting results of complete remissions of 90% and upwards, and some durable remissions over a year or more. Additional chimeric antigen receptor T cells and other genetically modified and targeted T cells are being developed for different forms of leukemia, different forms of hematological malignancy, and also for solid tumors. The third group of immunotherapy that we think about are targeted antibodies. So antibodies are proteins that can exist in your body and also can be infused in higher doses. And those antibodies are specific for particular molecules that are expressed on leukemias and solid tumors, for example. The antibodies can work in different ways. They can just alert the body's natural immune system to the presence of cells expressing those molecules, or they can be linked to particular toxins to be able to eliminate, deliver specific chemotherapy where the cancer is. And they can also be antibodies can also be linked together so that they can activate the immune system to clear the cancer better. So one of the earliest forms of antibody therapy is called rituximab, and that targets a particular molecule called CD20 that's expressed on a number of different B-cell lymphomas and has become a very integral part of clinical care for a number of lymphomas. Anti-GD2 antibody has been approved for the treatment of pediatric neuroblastoma, which is often a very hard to treat form of solid cancer in young children. An anti-CD30 antibody has been approved for the use of a form of aggressive lymphoma called anaplastic large cell lymphoma and Hutchinson disease. And another, the form of antibody therapy where it essentially an antibody that's targeting a molecule, in this case CD19 for blinatumomab, is linked to an antibody that's activating the healthy immune cells in the body to bring them together and activate the T cells. Lastly, very recently there's been a lot of excitement about checkpoint inhibitors. So checkpoint molecules exist on the surface of both the immune cells in the body and the cancer cells, and they're basically a brake on the effectiveness of the immune cell system in attacking and clearing cancer. And by blocking the brakes, allows the body's natural immune response against cancer and any introduce cellular therapies to act more effectively. So some of the exciting developments have been pembrolizumab, so anti-PD-1 for Hodgkin's lymphoma, which is approved, and also ipilimumab, which is a anti-CTLA-4, which has just very recently been approved for melanoma in patients 12 years and older. Apart from those molecules and cell therapies that have already been approved, it's really important that parents should be aware of the clinical trials that are bringing new therapies to patients. So the idea of clinical trials is to allow patients access to promising cutting-edge strategies that combine both new and old approaches. So this includes cell therapies with immune therapy and the different antibody and checkpoint molecules. So there's a much larger array of possible treatments that are in clinical trial at the moment compared to the fairly limited number of approved drugs. The immunotherapy clinical trials are all focused on effectively and safely harnessing the immune system's power and precision. And there are clinical trials available for all types of childhood cancer. And I'd encourage patients and parents to explore these options and don't necessarily think of them as a last resort. They really can open up new treatment options for exciting therapies that can treat very refractory cancers. So going forward, the directions in pediatric immunotherapy are improving the cell-based therapies. The cell-based therapies are, particularly in the genetically modified cell-based therapies, they're very new, and we have a lot to learn about how to engineer these cells very precisely for maximum effect and minimal toxicity. Blood and marrow transplantation is still a backbone of the cell-based therapies, particularly for hematological malignancies. And my research group is very interested in combinations of immunotherapy and blood and marrow transplantation, being able to make the process of transplantation more effective and safer. It's very important to recognize that the immune system is very complex, and any introduced immunotherapies may well work best in combination with each other. So there's a lot of activity going on to find out what is the right kind of combination of transplantation, targeted genetically modified T cells, antibodies, checkpoints, viruses, and vaccines. So we can combine new approaches, we can combine traditional approaches and new approaches. Another very exciting advance in the last decade has been the advent of molecular typing, sequencing of the genes in cancer cells, which has allowed us to understand the underlying biology of the cancer and understand how cancers that look alike might be quite biologically different. So that then allows us to identify treatments that are most likely to benefit individuals and guide decision-making in the clinic and directing patients to the right clinical trial for them. So again, that means bringing the right treatment to an individual patient at the right time in their treatment process. And with that introduction to the field, I'm very happy to take some questions now.
Thank you so much, Dr. Bleakley, for that excellent and I think easy to understand overview of what's available in pediatric cancer for immunotherapy. I was very happy to see, I don't know if folks are aware of just how much progress has been made in treating pediatric cancer patients. And so your first slide showing that up to 80% of, there's an 80% survival rate today, up from 20% back in the 60s, demonstrates the enormous progress that has been made. Of course, there's still farther to go. We want to get to 100%. And I was amazed to learn recently that one of the reasons why we've seen such progress is that there's a higher rate of enrollment in clinical trials among pediatric patients than there are among adults. The adult enrollment rate is, between 3 and 6% of eligible patients ever enroll in a clinical trial. And the rate for children is significantly higher. I think the number was, 60 or 80%. Do you know why? Is there a reason why we see a higher rate of enrollment, or are there just more trials or more options available for children than there are for adults?
Yes, Brian, that's an interesting question, and it's part of the history of pediatric oncology. Because childhood cancer is relatively rare, it's very hard for an individual doctor to gain enough experience in one particular form of therapy that they can be confident that that is the answer for a given disease. And so very early on, it was recognized that the only way to move forward and to make progress and improve the survival of childhood cancer was to get together and form groups, collaborative groups, to run structured clinical trials. And basically for a child with a given cancer, wherever they are in the country, to have them enroll on a standard treatment approach. And that could be with brand new therapy, but it could also be just using existing therapies in a standard form or a standard combination. So the individual pediatric cancer centers join together to form collaborative groups. In what the largest group is called the Children's Oncology Group, and the Children's Oncology Group, COG, has run many clinical trials across all the childhood cancers and has allowed forward progress to be made over the decades, explaining that improvement from 20% to 80% overall. That's the current name of the collaborative group, but it's existed in different forms, in different names, but that's the culture that has developed, that all children that have cancer should be offered the opportunity to participate in the clinical trial, so that the treatment that's given and the response of that child is that information becomes shared and allows us to see what's working and what's not working and move forward in the future. There are similar collaborative groups around blood and marrow transplantation. The pediatric blood and marrow transplantation consortium's been also very important in moving pediatric clinical trials forward. So it is the culture and the structure of pediatric cancer to have clinical trials available and to be presented to families in a positive way. We've learned with time, actually, that children that are enrolled on clinical trials tend to do better than children that receive similar therapies off trials. And part of that is thought to be just that they get a lot of support. There are many eyes watching the treatment of a child on a clinical trial.
Yeah, I was going to say that for parents going through treatment, finding the right treatment for their child, it can be. I imagine it would be both a frightening as well as a hopeful thing to expose their child to an investigational treatment in a clinical trial. So what sorts of questions or concerns do you most commonly encounter from parents who are considering enrolling their child in a trial?
So there are various forms of clinical trials. So the clinical trials that the majority of childhood cancer patients go on are large trials that use fairly established types of chemotherapy and adjunctive therapy. And the idea is just to use them in a structured way or a slightly different way than they've been used before and see if it improves the fairly positive outcome that those children are expected to have. So the questions from parents enrolling on those type of trials have to do with what are the advantages of doing that versus just having a similar therapy off clinical trial, just as a treatment plan. And the advantages really are to the individual child and the family that, again, if you're enrolled in a clinical trial, there are many people that are following your course, not only your own physicians, but the leading study physicians and the research teams that support that. So things are done and recorded in a very standard way, and it allows people to be very aware. For example, somebody's developing a side effect, there's a plan for how to deal with that side effect. So that's the advantage to the child. Often there's a question asked about whether we can use these existing therapies in a slightly better way, and if the child receives that particular approach, there's a chance that they could do better than they would otherwise with a standard approach. And then there's the sort of altruistic way enrolling in a clinical trial, and that's because that's the way that progress has been made. And if the community of families with children with cancer choose to sort of support that model, then we'll be able to move further forward. So that's one group of clinical trials. Others are other newer clinical trials. We say early trials or phase 1 or phase 2 trials, and they're really bringing brand new approaches to children and patients with cancer. And the great advantage of enrolling in those sort of trials is they often offer new treatments that aren't otherwise available, and they can be spectacularly successful and really provide a treatment option that an individual doesn't otherwise have.
What are some of the side effects that are most commonly seen in treating children with immunotherapy, and what is done about those side effects?
That depends on what particular immunotherapy you're talking about. So if we think about the groups of immunotherapy I presented before, blood and marrow transplantation is one of the most widely used immunotherapies. And we've learned a lot about blood and marrow transplantation over the last 50 years, and the very severe side effects and fatalities have come down tremendously just by experience and by focusing on the elements of the transplantation that that create problems such as the intensive chemotherapy and radiation, and also the need for sophisticated matching between donors and recipients. But we're still left with the side effects of using the intensive therapies before infusing the cells, and that's necessary in patients with cancer, not just to technically get the transplant to take, but it's part of the therapeutic effect against the cancer. So those therapies depends on exactly how intensively you have to use them and the age of the child. But for example, having to use an intensive blood and marrow transplantation regimen in a small child and baby, that person can be expected to have growth delay and potentially end up shorter than they otherwise would. It can interfere with their intellectual development so that they don't have the same intellectual capacity than they otherwise would. It can create problems with metabolism, with side effects on the strength of the cardiovascular system in the long term, and can contribute to a higher risk of cancers in later life. So that they're all fairly disturbing side effects of the current ways that we still need to deliver blood and marrow transplantation. That's the reason that we're working towards backing away from the intensive chemotherapy and radiation and making the cells that we administer to the patient as part of the transplantation process smarter and more able to effectively address the cancer and less likely to cause toxicity. If you think about the new engineered T-cell immunotherapy, such as the chimeric antigen receptors, they have quite a different issue with side effects. As far as we know, we don't expect to see long-term side effects in terms of growth and the other issues that I mentioned from them. But at the moment, we're seeing two groups of short-term side effects that patients and parents should be aware of, in that these are very active cells, and when they get into the body, they can create something called a cytokine storm, which is basically a lot of the proteins in the body that provide signals between elements of the immune system can get quite elevated and revved up, and those that cytokine storm can result in things that are fairly mild, like low-grade fevers and flu-like symptoms, or they can result in a whole body process where there's a lot of fluid leak and the fluid in the body is in the wrong place, so that the heart and the respiratory system needs to be supported. And a number of the patients go to the intensive care to have support during those times. Even in the few years that the chimeric antigen receptor therapy's been used, there's been a lot of progress made in how to anticipate and monitor molecules that predict those side effects. And it's now becoming more routine to give medicines that sort of intervene early in the process and prevent the most severe toxicities. The antibody therapies can have a variety of side effects depending on exactly what molecules are targeted and what the antibody is linked to. For example, some of the antibody therapy is linked to chemotherapy, and for various reasons that can disturb the liver and in some cases can disturb the kidneys. So those particular things should be considered when starting antibody therapy. The checkpoint inhibitor molecules work by taking the brakes off the immune system, and the side effects of those group of drugs are basically the result of a very activated immune system. So you can develop autoimmune-like conditions as a result of it. So they have to be given with caution for sure. But again, very, very powerful molecules that are making big inroads with patients that have very difficult to treat cancer. So I think when you're looking at integrating any of these new immunotherapies, it's really important to have an idea of what is likely to be effective for a given patient and what the side effect profile is, and to anticipate that. And in general, these new therapies are being given in the larger pediatric oncology and cancer research centers, where people are getting experienced with how to most safely give them to the patients.
It is certainly reassuring that we have learned a lot, and that, as you mentioned, doctors are able to identify in many cases what the risks are of adverse side effects, and kind of cut them off before they progress too quickly. I think the very first childhood patient to receive a CAR T-cell therapy, Emily Whitehead at UPenn Children's Hospital, experienced that cytokine storm in a very dramatic fashion, and it was very touch and go there for a while, until the doctors realized that it was happening because her immune system was working, and that in fact her leukemia was being wiped out at an accelerated rate, which resulted in the storm, and they were able to bring those symptoms under control. And of course now Emily, I think, is 6 or 7 years out since treatment, still free from cancer, and it's just an amazing story.
It is indeed.
What are based on your experiences in talking with parents, do you have any tips for them on how they can get the most out of their conversations with their doctors about whether or not they should enroll a child in a clinical trial?
I would suggest that parents feel very empowered to ask questions and come to their consultations prepared with their list. They shouldn't be shy about doing that. That's their role as a parent, is to really get the information that they need to contribute to the decisions that are being made for their child, and to feel comfortable with it all, so that they can communicate the information to their child as well. Make sure it's right for everybody, and that the pros and cons are well understood. So some of the questions that I would encourage families to ask about is, what is it? What is the new treatment that's being proposed? How does it work? What do we know so far about it? What's been learnt in previous human clinical trials, or perhaps in animals if there's not much clinical experience, if it's brand new? I think many parents would like to know what the probability of the new therapy being effective is, as far as it's known, and in particular whether there's anything known about whether their particular child's cancer is more or less likely to benefit from that immunotherapy. I think it's very important to be aware in general terms of the probability of severe and less severe side effects. And again, whether there's anything known about the particular child and their probability of developing the more severe toxicities. Some families would also like to know the details about the severity of the side effects and likelihood of responding to treatment for the side effects. And also important is the concern for late effects. There's the very scary short-term side effects, but then what does the family and the child need to be aware of for the future? And if they are likely to develop a particular long-term effect, that's going to be with them for life. So they're going to be kind of reminding their healthcare providers about what their risks are and what needs to be followed up and screened for.
Aside from the longer term follow-on effects of treatment that you mentioned, are there any considerations that doctors take into account when considering treating children with immunotherapy that are different from the considerations of treating older children or adolescents and even adults?
You're asking about young children and babies versus adolescents and adults. So that depends on the type of immunotherapy. In blood and marrow transplantation, it's very important what the age of the child is and what side effects are likely to happen. For example, growth is an important consideration in very young children, and a good reason to back off the most intensive preparative regimens where possible, whereas fully grown, almost fully grown adolescents, it's much less of a concern. Similarly, cognitive development, what is toxic in a 2-year-old is much, much less so in a 12 or 14-year-old. In terms of how patients handle the short-term toxicities of immunotherapy, there doesn't seem to be a great deal of difference, for example, in cytokine storms between children and adults. In fact, children in some ways, because their bodies are generally younger and more flexible, they can adapt to some of the stress of things like cytokine storm in ways that older adults are less equipped to deal with.
All right, well, that's unfortunately all the time we have for today. Dr. Bleakley, thank you so much. I hope that anyone who's watching who has a child who has cancer and is considering enrolling in an immunotherapy trial or receiving an immunotherapy treatment had some of their questions answered by watching and listening today. And certainly you make a very good point of encouraging parents to be courageous in asking all the questions that they can of their doctors to make sure that they're getting full information and understand both the immediate and longer term impacts or potential consequences as well as the benefits of treatment. So with that, I'd like to thank once again our sponsors, Bristol Myers Squibb, Genentech, Regeneron, and Advaxis Immunotherapies. And to remind you again that we do have this Immunotherapy Patient Summit series. And if you're in Chicago, New York, Houston, or Tampa, we encourage you to attend this free event. We also have the live streaming on September 23rd. We'll be streaming live from the New York event on that date. And of course, you're welcome to register for those at cancerresearch.org/summit. If you'd like more information about immunotherapy for childhood cancers, you can come to the Cancer Research Institute website at cancerresearch.org/childhood-cancer. We also have immunotherapy information for 19 other tumor types and categories. So if you're just watching this out of general interest in immunotherapy but have another type of cancer that you're specifically focused on, we may have information for you available on the Cancer Research Institute website as well. This webinar, it has been recorded and it will be made available at cancerresearch.org/webinars. You can also find us on our YouTube channel at Cancer Research Institute. Dr. Bleakley, thank you so much.
Very welcome. It was a pleasure. Thank you.
Bye-bye.